From Fatemohn Medical College and Hospital, Baleswar. And today I am going to teach you anemias. So basically, we are going to start from the basics of hematology. We'll quickly look at some of the basic things which we require to understand anemia. We'll build anemia step by step. Okay. I'll teach you briefly about the RBC indices also and stages of hematopoiesis so as to understand at what stage the cells are going to appear in different kinds of anemias. Then we'll classify anemias into your different kinds of hypoproliferative anemias and miscellaneous disorders of RBCs. Okay, we'll read about thalassemia, sickle cell anemias, hemolytic anemias, iron deficiency anemias, and all. I will write the things which you have to understand and which are theoretical things. We'll read from the notes. Okay, which are written by me only, so don't worry. And those who have been requesting me for endocrine and CVS one shots and all, one shots take time. Just be patient. In June, maybe if I get time, I will definitely cover the one shots and make the videos of that. Okay. So let's start with the anemias. So first of all, let me be very clear that we're gonna touch that level in which you can crack and questions of anemia from every exam, like for your NEET PG or USMLE, or even your first professional exams. This is very useful for your first props exam as well as second prop exam and all. Okay. So anemias, we're gonna do at a decent level, by which I believe that we can cover most of the concepts. Okay. Okay. Just a minute, background noise. Okay, so let's start our discussion. And now I'm switching off to my notes. We'll read some of the basic things from that quickly. We'll go through them quickly. And after that, we'll start our discussion of each anemia in detail. Okay, so let's switch first. So first, we'll are into the basics of hematology. Okay, my video pause. Okay. Basics of hematology. And in basics of hematology, we are going to do some of the things which are important first for understanding of your anemia. And first we'll look at the hematopoiesis. Hematopoiesis is the formation of all the cells. Okay, if I tell erythropoiesis, the formation of RBC, leukopoiesis, WBC, thrombopoiesis, platelets, you know that. Site is fetus. In fetus, we have the intrauterine life. The yolk sac is the major organ. Up to in the 8th week of intrauterine life, the hematopoiesis starts and stops around the 3rd month. Okay. In the 4th to 5th month, the organ is gonna shift to the liver and spleen. 4th month to birth, we have our bone marrow as the primary organ. Of course, other organs also contribute in this process, but I'm talking about the primary organ, which is for hematopoiesis. After birth, we have bone marrow plus every bone of our body. Every bone produces that blood cell. Okay, the all the hematopoietic functions. After puberty, we have the flat bones and the bone marrow principally. Okay, the long bones stop producing the blood cells because it is gonna be replaced by yellow bone marrow. Before birth, we have the red bone marrow, so hematopoietic. But after puberty, the long bones will not function as it will be replaced by fat. This is the yellow bone marrow. Okay. We're going to look at the stages of hematopoiesis. So first we have a pluripotent hematopoietic stem cell, PHSP, that is producing all the cells of our body. Okay, pluripotent, which have a possibility, which have a probability of producing all the cells. Okay, basics of umbilical cord blood storage. You might have been seen people planning for the umbilical cord blood. Okay, which is preserved for many disorders in future, which you might get. Okay, so umbilical blood storage is nowadays very popular. Then we have the pluripotent stem cell differentiating into multipotent hematopoietic stem cell that can produce RBC, WBC, and platelets. It will divide into two. One is the common lymphoid progenitor, one is the common myeloid progenitor. Okay, the lymphomas. Okay, the leukemias are originating from the common lymphoid progenitor is the origin of ALL, and common myeloid progenitor is the origin of AML. If you know, well and good. If you don't know, just leave it now. Okay, ALL and AML will be dealt in your leukemias and lymphomas. Okay, these are the tumors of the blood. Okay, leukemias and lymphomas are malignant tumors, right? We have no benign tumor in that. If you know, well and good, just understand from here. If you don't know, just skip. We don't need it in anemia. Then this common lymphoid progenitor will produce the B cell, T cell, and the NK cells, which are the cells of immune system. And the common myeloid progenitor will be forming four colonies. Okay, So we have a CFUE, that is colony forming in erythrocytes, CFUT for thrombocytes, CFUG for granulocytes, and CFUGM for monocytes. Okay. So this CFUE will form the erythrocytes, thrombocytes, this granulocytes. Granulocytes, the which have granules, eosinophils, neutrophils. Okay, these have granules. Then monocytes. Okay. Then we are going to discuss about erythropoiesis, right? Erythropoiesis is the first CFUE, of course, it will originate from CFUE, which is the immature cell, which has a high nucleocytoplasmic ratio. NC ratio is the nucleocytoplasmic ratio. It has a highest nucleocytoplasmic ratio. Okay, it has nucleus more than cytoplasm because it is an immature cell. Immature cell have more nucleus than cytoplasm. Then it differentiates into proerythroblast, okay, also called as pronormoblast, in which the hemoglobin production starts. Question comes that hemoglobin production starts at proerythroblast, but visible at, okay, here, what you can say, hemoglobin is visible first at intermediate normoblast. Okay, because now only you have the red color appearing. In the previous two things, you have the blue color only. So proerythroblast or pronormoblast will have cytoplasm, which is blue, and mRNA is more than the hemoglobin. So there is very, very, very less hemoglobin present. mRNA is more, so it appears bluish. Then we have the early normoblast, which has a slightly smaller nucleus. Still, the cytoplasm is blue. This both are called as basophilic normoblast. Basophilic means your basic stain loving normoblast, that is bluish blue color. So proerythroblast and early normoblast. After that, we have the intermediate normoblast, also called as polychromatic normoblast, because it has two colors, polychromatic. Okay, it has two colors here. You can see the nucleus becomes even smaller. So the size of nucleus you can observe is going on decreasing, right? And the balance between mRNA and hemoglobin is slightly normalized. So you have that much hemoglobin, that much you have mRNA, right? So we have the red and blue, you can see from the diagram. Then afterwards, intermediate to late normoblast. Late normoblast is called orthochromatic. Orthochromatic, that is completely red. So nucleus is very, very tiny, a dot nuclei you can say, and cytoplasm is red, right? After that, a event occurs which is called as pycnosis. Here it is not written. Event occurs which is known as pycnosis. Pycnosis is the ejection of nuclei out of the cell. The nuclei will be ejected out, then will form the reticulocyte. So reticulocyte has no nucleus because nucleus is ejected out, few ribonucleoproteins. So mRNA is very, very, very less now, and lifespan is 1 day. Okay, reticulocytes live for 1 day. After that, it differentiates into erythrocyte or RBC. So reticulocyte just shrinks inside. Reticulocyte is circular, spherical you can say, and it that bulges from the sides and depresses. There is a point of depression in the middle, right, like this. Okay, so it is your erythrocyte or RBC. Here you can observe. So here in the central part, it can't have RBC. It can't have hemoglobin due to this compressed part. Less hemoglobin will be present comparatively as compared to your sides. Okay. So this two part, part number 2, which is marked, has more hemoglobin than this one part. So if you see under the microscope, it will appear circular. Of course, if you are looking at the top, you can see here, if this is eye, you are looking at this angle. So it will have a circular background or circular shape, and center will be pale. It is called the central pallor. Central pallor. The central pallor is important from the diagnostic point of view because if it is a speroblast, okay, this is a sperocyte. In, for example, your a disease is called as your hereditary spherocytosis. There you will find sperocytes. So sperocytes will not have the central pallor because the RBC there is spherical. So uniform distribution of hemoglobin will occur. Okay. So these are the basics of hematopoiesis. Next, we'll go to the basics of anemia. Okay. Let's talk about the basics of anemia now. So anemia, we have the classification of anemia. So anemia is classified based on etiology, bone marrow, and microscopy. Etiology, bone marrow, and microscopy. So it is a very simplified classification. You have to remember this classification first. Then we'll move to as far we move, we'll classify it further. It will get complicated. So I'm not complicating the things from an early stage. You are early new to this anemia topic. And if you have studied also, you might be knowing very complex classifications of normocytic, hypochromic, or microcytic, hypochromic, proliferative, like that. Many things we might have known, but this is simpler classification which you have to keep in mind first. Then we can build anemia based on that. Okay. So based on etiology, we have the hemolytic or nutritional. Etiology means the cause. Okay. Based on the cause of anemia, we have hemolysis either, or we have nutritional deficiency anemia. Based on the bone marrow, we have a hyperproliferation. The anemia is caused by hyperproliferation of bone marrow or hypoproliferative anemias. Okay. Microscopic classification based on mean corpuscular volume. Okay, that is MCV. That is the volume of a single RBC. So based on that, we have a microcytic, we have normocytic, we have macrocytic anemias. Right. So let's talk about RBC indices. These are the basic things. That's why I'm not writing anything. Just I'm going slow also. I believe that you don't have any problem in understanding things. I will ensure that. RBC indices, and if anything which you have to understand like that comes, then I will surely write and tell you. Okay. So basically, look at this. MCV. MCV is the mean corpuscular volume. Mean corpuscular volume is the volume of a single RBC. So we have MCV equal to packed cell volume upon the RBC count. Packed cell volume is the volume of complete RBC. Okay, in that sample, and then we have the RBC count. Okay, divided by RBC count. So total volume upon number of RBCs will give volume of single RBC, right? So volume occupied by single RBC will be given by that. Normal MCV, you have to remember this. 80 to 96 femtoliters units are important. It may be converted to any other means. Femto means 10 to the power minus 15 liters, right? So less than 80 will be calling as microcytic. 80 to 100 will be calling as normocytic, and more than 100 will be macrocytic. Okay. So microcytic will find that you can remember this by a mnemonic SITA, SITA. Okay, you can remember this SITA by this mnemonic. So one is the sideroblastic anemia, I is the iron deficiency anemia, and T is the thalassemia, and your anemia of chronic disease is the last, right? So most common cause the iron deficiency anemia. You might be knowing that most abundant anemia that is in India is your iron deficiency anemia only, right? So it will be, of course, the most common cause of that. Then we have normocytic. Normocytic means will have the normal range of your MCV. Okay. So anemia of chronic diseases, anemia and CKD and aplastic anemia. Chronic diseases, CKD and aplastic anemia. CKD is chronic kidney disease if you don't know, and aplastic anemia. These are the normocytic anemias. And more than 100 is your macrocytic. Macrocytic anemia will be most common. Most common you can say, but most obvious cause. Okay, most obvious cause is the megaloblastic anemia. Megaloblastic anemia will have macrocytic anemia because the volume will increase, of course. Okay, because the RBC's size is more now. Okay, the volume will be increasing. Then alcohol induced anemia, liver diseases, and hypothyroidism, that is the metabolism will be slowed down. There's slowing down of metabolism, the membrane have to work less, so membrane will bulge out. It will be weak like that, so it will form the macrocyte. You can see that weak membrane. Important thing, we'll have our RDW. RDW is the red cell distribution width. RDW. So RDW, how to calculate? MCV is 80 minus 96, right? 80 to 96. So RDW is just minus the higher limit from the lower limit. So RDW is 96 minus 80. 96 minus 80, it is 16. Okay. So normal RDW is 16. 96 minus 80, higher limit of MCV minus lower limit of MCV. It is a degree of RBC size. How in a proportion the RBC size are decreased. Okay, it is a degree of anisocytosis. The shape variation in RBCs, it is a degree of anisocytosis, right? So here we are comparing the RDW of iron deficiency anemia and the thalassemia trait. Okay, iron deficiency anemia and thalassemia trait, we are comparing the RDWs. Okay. So iron deficiency anemia is the most common nutritional deficiency anemia. Okay. It has a dynamic pathogenesis. Okay, the pathogenesis is dynamic. Just a minute. Understood? So dynamic pathogenesis means the nutritional deficiency varies. Okay, according to the nutrition you take, nutritional deficiency will vary. But in genetic abnormality, we'll have a static pathogenesis. That is, the causes will be static at that point. That much mutation has occurred means occurred. Okay, you can't really increase or decrease that mutation or that. Okay, so nutritional deficiency anemia will have a dynamic pathogenesis. That's why decrease iron, so microcytic anemia, normal iron, or normocytic anemia. It can have this iron deficiency anemia can manifest as microcytic or normocytic anemias. Okay, just a minute. Okay, so microcytic, let's say the MCV is 65. So higher limit is 96, obviously. So how to calculate the RDW? We have to minus the higher limit from the lower limit from the higher limit. So 96 minus 25 will be 31. So iron deficiency anemia, microcytic one, will be this wider RDW. Okay, this iron deficiency anemia will have a wider RDW. After that, let's talk about thalassemia trait. Thalassemia trait will be due to mutations. So it has a static pathogenesis. You can't alter the mutations to higher or lower levels, right? So RBC is always microcytic. It is not that we have a normocytic RBC. It will be always microcytic. So MCB will be 65 to 80, let's say. So RDW will be 80 minus 65 is 15. That is normal RDW. Okay. So thalassemia trait will have a normal RDW. Iron deficiency anemia will have a wider RDW. So those pathogenesis in which there is a dynamic pathogenesis generally have a wider RDW, right? Let's talk about the Metzer index. Metzer index. Metzer index is the differentiate between iron deficiency and thalassemia. To differentiate between iron deficiency and thalassemia, we have a Metzer index. Okay. So MI equal to MCV by RBC count. MCV by RBC count. So volume per single RBC divided by the RBC count is the Metzer index. In thalassemia, what happens? The MCV will decrease, okay, and RBC count is increasing. In thalassemia, the RBC count is increasing. We'll see how. Okay, so it will be the Metzer index will be less than 13. Normal Metzer index is 13. Okay, and iron deficiency anemia, MCV is decreasing and RBC count is decreasing. So it will have a greater Metzer index. Okay, so it will have more than 13 Metzer index. That is about Metzer index and RDW. These two are not important for your first year point of view. If you are a first year medical student, then IDW and Metzer index are basically not asked more commonly. It a little at a higher level, right? So you can ignore first year student, but second year you have to read. And questions are there from US Emiliano. Metzer index can be given as a finding, or RDW can be given as a finding, pathological finding, serological finding, you could say. Okay. MCH, mean corpuscular hemoglobin. The hemoglobin present in a single RBC. Normal is 27 to 32 picogram. 27 to 32 picogram. Less than 27, hypochromic anemia. Hypochromic anemia, that is less hemoglobin. Can we have a hyperchromic anemia? No, because our hemoglobin count can't increase, right? It can't increase in a cell. It can be decreased or normal, right? How can it increase? So hypochromic anemia means it will have more than one third failure. So we have one third failure is normal. More than one third failure means it indicates the hypochromic anemia. MCH is the mean corpuscular hemoglobin concentration. Okay, if it increases, then it's called as perocytic anemia. If it increases, we'll call it as perocytic anemia. Normal is 32 to 35. Mean corpuscular hemoglobin concentration. Understood? Then we have a retic count. Retic count is called the reticulocyte count. Retic count is reticulocyte count. That is reticulocytes, immature RBCs and all. Okay, which doesn't have a nucleus and lifespan is 1 day. I would talked about that. Normal is, you have to remember very importantly, 0.5 to 1.5% is the normal count. If it increases, it increases in the hemolytic anemia and hyperproliferative anemia. Hyperproliferative anemia, what happens is that the bone marrow is continuously producing cells. So you must have heard that jaldi ka kaam saitan ka. Okay, so what happens is that when it starts, it steps up its production, then immature cells are produced more and more. So hyperproliferative anemia will have increased reticulocyte count, and hemolytic anemia also. We'll see how. Okay, so that's about the introduction to anemias. I hope you understood all of the things that I taught. Now let's move on to the next part. Okay, so let's discuss now about the hemolytic anemias. Okay, then we'll move to the other types of anemias and iron deficiency ones. So hemolytic anemia, we'll first see from this PDF how we can differentiate between intravascular hemolysis and extravascular hemolysis, and what are these. Okay, if you understand intravascular and extravascular hemolysis, we can extrapolate many symptoms which we'll find in different kind of anemias. We'll see how useful it will be. Okay, just understand very carefully. If we RBC lyses inside the blood vessel and or if your RBC lyses outside the blood vessel, and what symptoms it will create. Okay, so you can write many points. If you know just the intravascular extravascular hemolysis, you can write many points about the anemias. Okay, so just understand, if the RBC lysis occurs based on location, if it lyses inside vessel, we call it intravascular hemolysis. If it lyses inside the spleen or liver, outside the blood vessels, we call it extravascular hemolysis. Okay, let's talk about intravascular hemolysis. So what happens? Here is a vessel. Here is a vessel. If there is a RBC lysis, the hemoglobin will be released outside. Okay, into the serum. So we'll have hemoglobinemia, that is increased hemoglobin in the serum. Right. First finding is the hemoglobinemia. Okay. Lysis will occur, so there will be increased LDH levels. You know, LDH is a marker or of lysis. Anything which lyses, okay, obstruction and lysis. LDH is a marker, so LDH level will increase. So every anemia which will have an intravascular hemolysis will have increased LDH levels, right? If hemoglobin will be released into the serum, it will obviously break down into heme and globin, right? So globin will be recycled, globin will go to the amino acid pool and will be recycled. And this heme basically has iron. So iron will go to the liver. It has four fates basically. Iron has four fates. Either it will combine with the haptoglobin. Haptoglobin is the iron carrier. So haptoglobin combines with heme and makes it less toxic. So it is the carrier which will combine with it and make it less toxic, right? So if it combines with haptoglobin, then the levels of haptoglobin will fall. So this intravascular hemolysis will cause fall in haptoglobin levels, right? Some will become methemoglobin, okay, methemoglobin. So methemoglobin levels will increase, right? It can go to the kidney and cause hematuria. Okay, this PCT has a capacity of absorbing 99% of materials. So PCT will absorb everything. Okay, and there will be heme deposits in the PCT. The PCT will have heme deposits, and this heme over a period of time will cause hemosiderin deposits. Okay, and whenever the PCT cells will die, the cells will set up. There will be hemosideриnuria. Okay, hemosideриnuria only seen in case of chronic hemosideриnuria. Okay, so there is basically the release of hemosiderin in the urine, hemosideриnuria. This is one of the findings of intravascular hemolysis. Then, if it goes to the liver, there will be increased bilirubin levels. So we'll have hyperbilirubinemia. Hyperbilirubinemia. Okay. So these are the findings of intravascular hemolysis. So what are the findings? First, hemoglobinuria. Okay, hemoglobinemia, that is increased hemoglobin in the blood. Then lysis will occur, so our LDH levels will increase. Then it may combine with haptoglobin and cause decrease in haptoglobin levels. It may become the methemoglobin. Okay, so it can increase the methemoglobin levels, or it can go to the kidney and cause hematuria. Hematuria will occur for sure, but if it occurs for a chronic condition, then the uh, heme deposits will hematuria means red urine will be there for sure. So in every anemia that has intravascular hemolysis, there will be red urine, right? So heme deposits in PCT that will cause a hemosiderin laden deposits, and this can cause hemosideриnuria if PCT cells die. Cells will die means obviously the hemosiderin will leak out, right? Then it may go to liver and increase the bilirubin levels, hyperbilirubinemia. This is hyperbilirubinemia is a common finding, right? It is not a specific finding. It will be seen in intravascular and extravascular hemolysis. We'll see how. These are the findings. Let's come to extravascular hemolysis. Extravascular hemolysis means outside the blood vessels. So what happens most commonly in splenic macrophages? The splenic macrophages are also known as something called the littoral cells. Littoral cells. Okay. So littoral cells will be engulfing the RBC. Okay. Then hemoglobin will increase inside the littoral cell. Okay. So there will be no hemoglobinemia. There will be no hemoglobinemia because it is not leaked out into the serum. The hemoglobin is inside the macrophage. Okay. It is not leaked out. There will be no hematuria like that. It won't go to kidney, right? The iron will won't go to kidney. No methemoglobin formation. The iron won't go to the combine with the that hemoglobin and all. There will be no hemosideриnuria, right? PCT cells won't get this hemosiderin laden deposit. And normal haptoglobin, because haptoglobin is not bound, it is free. Okay, the levels are normal. LDH levels are also normal. But macrophage, in the macrophage, the hemoglobin is increased inside that, so there will be splenomegaly. Of course, there will be splenomegaly and increased bilirubin levels, that is hyperbilirubinemia. There will be increased bilirubin levels for sure. Okay, uh, so there is hyperbilirubinemia. Done. So two findings: your splenomegaly and increased bilirubin. Done. Okay, so every hemolytic anemia has a triad. So just remember the triad of hemolytic anemia that are common features for both intravascular and extravascular hemolysis. That is increased bilirubin first, decrease in lifespan of RBC, decreased lifespan of RBC, and bone marrow hyperplasia. Okay, bone marrow hyperplasia. That is reticulocyte count will increase more than 1.5%, is a feature of every hemolytic anemia. So increase bilirubin, decrease lifespan of RBC, and bone marrow hyperplasia. Increase bilirubin, decrease lifespan of RBC, and your bone marrow hyperplasia. Done. Next, we'll come to the diseases. Next, we'll come to the anemias one by one. So from now onwards, I'll be writing the things because it will be more like understandable as per your PPT. Just a minute. Okay, let's start from here. Right. So first, we'll discuss your hereditary spirocytosis. Hereditary spirocytosis. So hereditary spirocytosis, just understand what I'm saying you. Okay. Basically, we have RBC membrane, and in the RBC membrane, we have proteins, the cytoskeleton of an RBC membrane. Okay. So let's say here is the RBC membrane. This is the RBC membrane. This whole part is the RBC membrane. Just let me shade it red. This is the RBC membrane. This is the outer part, outer membrane, and this is the inner membrane. Okay, this is the RBC membrane. And below the RBC membrane, we have spectrin protein. Here we have the protein called spectrin. Spectrin. Then outside this here, didn't know it happened like that. I'm erasing this. Okay, at the outer membrane, we have a protein called as band 3. Here we have a protein called as band 3. And the protein which is linking spectrin, okay, which is holding on to spectrin, this one, this protein which is holding on to spectrin is called as the ankyrin. And the protein which is linking band 3 with the ankyrin, this part, is called as a band 4.2. It's called as a band 4.2. Understood? We have spectrin, inner membrane, we have ankyrin, band 3 over the outer leaflet, and band 4.2, which will be holding this band 3 and the ankyrin. These are the RBC membrane proteins. These are the RBC membrane proteins. So most common etiology is is ankyrin mutation. This ankyrin is mutated. It's the most common part, most common. Or it can have a spectrin mutation, it can have a band 4.2 mutation, or any of them. But most common mutation is the ankyrin. So basically, the etiology will be loss of RBC membrane protein. So RBC membrane proteins, these are lost. This is the problem. Understood the problem? And it is a most common autosomal dominant inheritance is most common. Autosomal dominant inheritance is most common. So what will happen if this protein, let's say, is mutated? The RBC membrane will be not be like that. This was the shape. So it will be like this. It will be wholly spherical. So what will happen is that there will be shape change of RBC to this, and with shape change of RBC. Okay, and when it goes into the spleen, spleen have some sinusoids. Okay, these are the splenic sinusoids. and the pores of spleen. Okay, so this type of RBC will not be able to move out. This will not be able to move out, and it will lies here. It will lies here inside. Lies inside. If it lies inside, which hemolysis will be there? It will be first. It will be trapped. These are the splenic sinusoids. Okay, just remember these are the splenic sinusoids. So due to its greater size, it will be trapped inside and it lies inside. If it lies inside, it will cause an extravascular hemolysis, right? Extravascular hemolysis. And after lysis, it will be eaten up by the splenic macrophages. Okay. So extravascular hemolysis means two features. Can you identify? One is the increased bilirubin, then splenomegaly. Understood? So autosomal dominant condition mean the history will be adult patient, a middle-aged adult patient, and it will have early presentation or late presentation. It presents late in life. Autosomal dominant that inheritance means only one gene is mutated. That is, it will present late in life, late presentation. The clinical features will be increased bilirubin and splenomegaly. Only since autosomal dominant condition is there, only one allele is mutated. Only one allele is mutated. That's why 50% RBC will be defective, 50% defect plus 50% spared. So 50% defect means we'll have a mild hemolytic anemia. Mild. So clinical features you can write mild hemolytic anemia. Mild hemolytic anemia. Understood? Mild anemia means RBC, your hemoglobin levels will be 10 to 11 milligram per deciliter, right? Mild hemolytic anemia. Okay, understood. And this increased bilirubin means how will diagnose. The diagnosis will be increased bilirubin. What it can cause? It can cause it gallstones. Okay, so gallstones may be present. Gallstones may be present or absent depending on that. Okay, splenomegaly will be obviously be there. Okay, uh, so these are the basic findings, the clinical features, and the history. After that, let's move into the CBC. So you ordered a CBC. If you ordered a CBC, what will be there? First thing, the MCV will be normal. MCV will be normal. Why? What is the effect on volume? Mean volume never will alter. Okay. This if the 50% are spared, 50% is there. If you calculate the mean volume of all that, it will be never be. It will more or less be same. Okay. But MCHC will increase. The more concentration, there'll be more concentration in the spherical RBC, right? The mean corpuscular hemoglobin concentration will be more concentration in the spherical RBC, so it will obviously be increased. Okay, this is the CBC finding. And what will be the peripheral smear? The peripheral smear examination. If you take a blood smear, the tongue-shaped blood smear, then this RBC will look what like that. This has become this, right? And spherocyte means if here there was central pillar, but here there will be no central pillar. So this is called a spirocyte. Spirocyte. It will look a bit smaller. It will look a bit darker and no pillar. So very easy to identify spirocyte. Okay. So most common cause of spirocytosis is autoimmune hemolytic anemia, AIHA. We'll read about that. Okay. And spirocytes will be found. And next step, if this spirocyte is not a specific finding for this hereditary spirocytosis, so it is most common seen in AIH, autoimmune hemolytic anemia. So how can you differentiate the autoimmune hemolytic anemia from this? So we have something called as a Coombs test. Coombs test. If it comes positive, then we'll call it as autoimmune hemolytic anemia. But if it comes negative, then we'll know that there is a hereditary spirocytosis because mutations are rare, right? So hereditary spirocytosis is basically mutation related. Autoimmune hemolytic anemia is common, right? It's autoimmune condition. It can occur. So, what is the investigation of choice? Every anemia will have an investigation of choice. How can you investigate the anemia? So basically, we have a flow cytometry, which we use is the most common EMA flow cytometry. Flow cytometry. Very easy. Don't be like that confused. EMA means eosin 5 melamide. Eosin 5 melamide. This is a full form. Just remember, EMA is a dye. Just understand, EMA is a dye. So basically, if you have a RBC and a here you have the band, which one? Band 3, right? Band 3 protein present. Okay. The EMA dye binds to this part. The EMA dye will bind to this part, and if the EMA will be positive, if the EMA flow cytometry is positive, means there is a normal person. It is normal. But this EMA is absent. That is, if there is no band 3, how there will be no band 3 if there is a RBCL spherical? Then the band 3 will be lost. So band 3, if it is gone, then we'll call it as disease. So you can just say that it's a hereditary spherocytosis. This is one. And another identification, you can do flow cytometry. You can do flow cytometry. Or you can do flow cytometry. So flow cytometry, what will do, that the spherical RBC, you just know that the spherical RBC, the spirocyte, you can say, the spirocyte is osmotically fragile. It is osmotically fragile. If it is osmotically fragile, then it will be lysed. It will be lysed at the normal lysis. There is a graph actually. If I want to tell you, there is a graph. This is the percentage of. We will do the saline concentration. We'll take saline concentration on this axis and percentage of hemolysis on y-axis, right? So this is the percentage hemolysis, and this is the saline concentration. So the RBC lysis at normal lysis will occur at normal lysis occurs at 0.4 to 0.5% saline concentration, right? So this is the, let's say this is the normal lysis. This type of RBC will rise at what concentration? There will be right shift. The spirocyte will rise at there will be early rupture. Okay, early rupture means right shift. There is a right shift. Right shift means 0.6 to 0.9 will be raised. Don't need to go into that detail of how this is happening. You can use the concepts of fluid dynamics and osmosis to know more. Okay. So what is the treatment? How can you treat it? What do you think? Mutations are irreversible, obviously, and there is a mutation only. So splenectomy is the only way of treatment. Splenectomy. Do splenectomy. Increased spleen will cause problems. Do splenectomy. Right. So that completes your hereditary spherocytosis. I hope I covered all the aspects. Band 3 and all, RBC in dominant, and this late presentation, CBC, MCB normal, MCS increase, peripheral smear I told, this part, flow cytometry and splenectomy lysis. Done? Okay, this was the first. Then come to second. Second, we are going to discuss about G6PD deficiency anemia. Do you know about G6PD? Do you know about G6PD? If you have read the HMP pathway, okay, there is a step where glucose 6 phosphate is being converted into 6 phosphogluconate, and this NADP H plus H plus, this NADP H plus H plus has been converted into NADPH. Okay, here we require the enzyme G6PD. Here we require the enzyme G6PD, and this NADPH, you know, is recycling the glutathione peroxidase. Recycles glutathione peroxidase. So this glutathione peroxidase is basically an antioxidant. Glutathione is an antioxidant, right? So basically, when you have decreased NADPH due to this deficiency, G6PD deficiency, obviously this step won't occur, and there will be decreased NADPH. So decreased NADPH means decreased glutathione peroxidase means decreased antioxidant, and decreased antioxidant means your increased ROS exposure. Increased Antioxidant is decreased means there are formation of more reactive oxygen species. So there is more ROS formation. More ROS formation means that will kill the RBCs, because WBCs won't be killed because they have nucleus. Okay, many they can produce new enzymes and protect themselves, but they will kill the RBCs. Kill RBCs. This is the etiology. Inheritance is X-linked recessive condition. It is a X-linked recessive condition. It is a X-linked recessive condition. Defect is intracorpuscular because these enzymes are present inside the RBCs only. Okay, so we have an intracorpuscular defect. Corpuscle means RBC only. Intracorpuscular defect. If I talk about pathogenesis, then what basically it is occurring? Okay, what thing is occurring here? Pathogenesis. What is the problem occurring here? Okay, so basically we have increased ROS production. Increased ROS. Increased ROS will increase the lipid peroxidation and mechanism for lipid peroxidation and increase the protein denaturation. Okay, it will increase lipid peroxidation and will also increase protein denaturation. Okay, increase the lipid peroxidation, increase the protein denaturation. So this high ROS, if the ROS is very high, okay, increase increase lipid peroxidation means it can either cause production, it can cause the production of free radical species, and it can damage RBCs. Either it can cause an intravascular hemolysis, either it can cause intravascular hemolysis, or can cause your spirocytosis. If the concentration of ROS is little less, then it can only damage the membrane only. Okay, it can cause spirocytosis also. Spirocytosis. So you can find spirocytes here also. You can find spirocytes here. I told you spirocyte is not a specific finding, it's a common finding, right? If it does protein denaturation, that is precipitation of hemoglobin, the hemoglobin is precipitated, then it will form clumps inside the RBCs. Okay, it will form this type of clumps. This protein is denatured. Okay, this protein is denatured. This damaged protein will form clumps like this type of clumps, and this type of clumps, this clumps of protein, when it is seen from the top, it appears like this. This, and here is a clump. Right. This type of inclusions are called as hinge bodies. Very important. Hinge bodies. Hinge bodies. Okay. Hinge bodies. And this RBC, if you see this RBC under the staining, under different stains, if you see this type of RBC, if you put something called as a Romanovsky stain, do you know Romanovsky stains? For example, Leishman stain. Leishman stain. You'll see something like this. The hinge bodies won't appear. You'll see this type of RBCs. The portion where the hinge body is absent, is basically the RBC becomes this like a chopped up thing. You have a that Lotti Choco pie, and you chop up one bite. Okay, it will look like that. So this type of cells are called as bite cells. Bite cells. Bite cells. Understood? So this denatured globin is not stained, right? And if you put some stain like crystal violet or your new methylene blue, then you can see the hinge bodies. You can see the hinge bodies here. Something blue things will be seen like this. New methylene blue and this type will see some blue structures here like this. The RBCs will be like this, and you will find that the hinge bodies will be present a little bit darker like this. You can see the hinge body. Can see. Okay. So these are the hinge bodies, bite cells. I told about that. So if you see a microscopy, If you see the microscopy, then you can see this. Okay. First, another thing is that this is a trigger-induced phenomenon. This is a trigger-induced hemolysis. Very important. Trigger-induced. Trigger-induced means that the most common trigger is inflammation. If there is more inflammation, then this phenomenon will be more. Okay. The most common cause will be inflammation. But we have few drugs also. So if a person comes to you with inflammation and effect of these drugs like primaquine, sulfonamides, or consumption of faba beans, or consumption of faba beans, okay, or consumption of dapsone drug, okay, then you can think of this type of thing. Okay, so diagnosis is based on that. So diagnosis is basically a person will come to you with any inflammation and hematuria will be present. Of course, red urine will be there. Red urine will be there. Red will be all the features of intravascular hemolysis will be there. Features of intravascular hemolysis plus consumption of these drugs, or you can say inflammation or inflammation present. So you can think of this condition. Okay, it will be like that. CBC will have decreased hemoglobin, obviously, decreased hemoglobin. Yeah, just normal finding. Peripheral smear, I told you, if you put the Leishman's, then spirocyte will be seen. This is the peripheral smear I was talking about. Okay, and this is the peripheral smear findings. You can know from that. And treatment is symptomatic treatment. Treatment is very just symptomatic. Stop the trigger. Stop trigger. First, stop the trigger was the thing which is causing this. Just stop that first. Okay, understood. So that completes our G6PD deficiency anemia. And now let's move to our sickle cell anemia, right? Let's move to the third one, sickle cell anemia. Sickle cell anemia. Let's discuss this. So sickle cell anemia, basically it is a hemoglobinopathy. Okay, it is a qualitative hemoglobinopathy. It is a qualitative defect, first thing. Qualitative defect means there is a qualitative change in the hemoglobin. The hemoglobin produced is of inferior quality, and thalassemia is a quantitative defect, means there is a decreased quantity of hemoglobin production. Okay, both are genetic defects, but it is qualitative and that one is quantitative, right? Thalassemia is a quantitative hemoglobinopathy. Qualitative defect or hemoglobinopathy, you can say. So hemoglobin, has a alpha chain and a beta chain. The gene coding for the alpha chain is present in chromosome number 16, and for the beta chain is present in chromosome number 17, right? Just a minute. Okay, so the tab is getting heated up, so just I'm closing my video. Okay, no problem. We can do without the video also, and after that we'll try switching off the camera again. None. Okay, so basically I'm telling that the sickle cell anemia, hemoglobin have alpha and beta chains. Alpha chain is present chromosome number 16, it is coded by that, and beta on chromosome number 17, right? So etiology is that first thing, it is the defect in the beta chain. So what happens is that the etiology, I'm talking about the etiology. So basically the beta globin chain at the sixth position of beta chain, the sixth position of beta chain will be a point mutation. There will be a point mutation there. So point mutation, what happens? The glutamic acid is changed to valine. Glutamic acid is changed to valine, and valine, is a hydrophobic amino acid. Is a just a minute, hydrophobic amino acid. Okay, due to which the hemoglobin becomes less soluble. Hb becomes less soluble. Less soluble. Okay, so it will start to precipitate. It will start to precipitate. So less soluble means what will happen is that there will be clumping, okay, precipitation occurring. So this type of clumping will be there. RBC will be clumps formed. Okay. So this clumps, there will be clumping, that is precipitation. This clumps will hit walls, will hit the walls and destroy. Okay. So here also you can see spirochetes. Spirochetes. It may be present or absent. Okay. It can form spirochetes technically. Understood? So this clumps, after this clumps, after clumping, or it can form this type of RBC. It will precipitate out and form this type of RBC, having this type of hemoglobin inside that. Okay, it will take the shape of a sickle. It will take the shape of a sickle, sickled to withstand the oxidative stress. Okay, it will be sickled. So basically, the inheritance is autosomal recessive inheritance. Autosomal recessive inheritance, and defect is intracorpuscular. Defect is within the corpuscles. These mutations and all are happening, right? So we have the intracorpuscular defect. Understood? Sickled RBCs. So sickled RBCs are basically, we'll see what are the complications and all, but what are the factors promoting sickling, which promote sickling, and the factors which inhibit sickling. What are the factors? So the factors which are promoting the sickling are basically your hemoglobin HbSS, that is sickle cell, not the trait, it is the disease, sickle cell disease. Okay. And the hemoglobin AS, that is a sickle cell carrier or trait, will inhibit sickling, carrier or trait. Okay. It can cause less sickling. MCHC increase will promote sickling. MCHC decrease will inhibit sickling. Okay. pH decrease will increase sickling, and pH increase will decrease sickling. Understood? Deoxygenation will promote sickling. Oxygenation will inhibit sickling. So these are few of the factors. Okay. And just know that sickling is a reversible process. Reversible process. Okay. This type of RBC, when it becomes sickled, when the clumps will come, okay, and it becomes sickled, it can revert back to this type. It can be revert back to this type. But this is called as recycling, right? But due to this excess recycling, if there is an excess recycling, it will cause irreversible damage, and it will be stuck in sickle state, stuck inside the splenic sinusoids. Okay. So this type of sickled RBCs can't move through the splenic sinusoids again. Okay. It can remain stuck here like this. Just a minute. It can remain stuck here, and it can cause hemolysis. So this is also an example of extravascular hemolysis. Extravascular hemolysis means, what are the things which are there? Extravascular means there is splenomegaly present and increased bilirubin. Right? Okay. This type, it can cause another complication. You can say this type of sickled RBCs can have a tendency to clump together. This can cause clumps. This type of sickle RBC can form dents, and these dents can occlude with each other, can combine with each other, can form clumps. So this can form a layer type of thing in this blood vessel. So if this is a blood vessel, it can form a layer type of thing that will occlude the flow of blood. It can occlude blood flow. If it occludes blood flow, then it is called as a vaso-occlusive vaso-occlusive crisis. Vaso-occlusive crisis. Okay, vaso-occlusive crisis. There are many vaso-occlusive crises. The most common vaso-occlusive crisis, most common, is called the dactylitis. Dactylitis is the due to occlusion of this digital arteries, the arteries in your fingers, okay, in your digits. There is a vaso-occlusive crisis. Okay, it can cause your gangrene formation. Okay, or it can cause leg ulcers, non-healing leg ulcers. Okay, non-healing leg ulcers, or it can cause priapism. Priapism is a painful erection, okay, due to venous occlusion. 40% males, even with this type of 40 to 42% males suffer from priapism with sickle cell anemia. Okay, 40% patients of sickle cell anemia, male patients, suffer from this priapism. Okay, and in spleen, we know splenectomy will be there. Okay, and recurrent pain will be there. Recurrent pain will be present. Okay, and over years, it can due to this occlusion, it can cause autosplenectomy also. Autosplenectomy can cause autosplenectomy also. Okay, and you will also have bone pain associated with this condition. Okay, CBC will be again like that previous condition. Okay, the hemoglobin will be decreased, the G6PD1. Peripheral smear will have some specific findings. First one, you know, sickle cell RBCs, sickle shaped RBCs, not sickle cell, sickle shaped RBCs. We also know that spirocytes can be found. Spirocytes can be found, positive or negative. And third one is the target cell. Target cell. What is a target cell? Is that most? It is not specific. It is not the specific condition. Let's say this is the RBC, and in the target cell, the hemoglobin will be present like this. There's a first. Just a minute. Let me make it less thick. Here there is this type of appearance of target cell. Okay. In this peripheral part, in the bulge part, there is no hemoglobin. In bulge, but there is hemoglobin inside this. So this is a target cell. It will appear in this type of cell. Okay, you can see the targets, the dart targets. Okay, these are type of target cells. And how to identify the investigation of choice is hemoglobin electrophoresis. Okay, HB electrophoresis. Understood? Complications. We talked about one of the complication. One of the complication is your that vaso-occlusive crisis. So first one is the vaso-occlusive crisis. Second one is a syndrome called acute chest syndrome. Acute chest syndrome. This is one of the complication. Acute chest syndrome means the emergency complication due to occlusion of pulmonary arteries. Pulmonary arteries occluded. So the patient may present with dyspnea, chest pain, hyperventilation. Okay, these are the clinical features of acute chest syndrome. Right? Treatment, how can you treat it? So treatment of acute chest syndrome, might you have guessed that 100% you will give that oxygen. Okay, but you have to maintain a saturation SpO2 of 100% first, the oxygen saturation, and you can use drugs like hydroxyurea drugs. Okay, this type of drugs increase the fetal hemoglobin level. HbF has a gamma chain, you know, alpha to gamma 2, right? So it will hold more oxygen affinity. This is more oxygen affinity, right? It will cause reverse sickling. It will cause reverse sickling. Or you can do a transfusion. Done? Okay. Next comes our fourth disorder, that is a thalassemia. Thalassemias. Okay. So now we are into our fourth disorder. Three hemolytic anemias we discussed now. Then we'll do the thalassemia. So thalassemia means this. Thalas means sieve. Thalas means sieve. Okay. Thalas means seed. This alpha chain, is present on chromosome number 16 is being coding for the alpha chain, and beta, chromosome number 11. Alpha chain has 4 alpha alleles present, and this beta chain will have 2 beta alleles. Okay, it is a quantitative defect or quantitative hemoglobinopathy, first discovered around the Mediterranean regions. Okay, none. So beta thalassemia. Let's first discuss about the beta thalassemia one. Okay, beta thalassemia. Okay, beta thalassemia. So beta thalassemia is basically a reduced or absence of beta chain. Okay, reduced or absent beta chains. If there is a reduced beta chains, we call it beta thalassemia minor. If there is absent beta chain, we call it as major. Okay, beta thalassemia major. So most common mutation, most common cause, the etiology is called as a splice site mutation. Splice site mutation. Splice site mutation. Okay, splice site mutation means, let's say here's an exon, E1, E2, E3. Exon and introns, I hope. Okay, and here is the intron one, I1 and I2. Let's say this is the normal splicing. So now in the normal splicing, what will happen? These exons will be joined like this: E1, E2, E3. Right. But if there is a splice site mutation, what will happen? Let's say this is the splice site. This is the splice site. So there is a mutation here. So what will happen is that an exon 1 will be there. Okay. Exon 2, exon 3 will be linked, but an intron will be remained like this. I1 will remain. Okay. This is a splice site mutation. It will never produce the beta chain. It won't produce the beta chain, and it will produce any random protein. Right. Any random protein will be there, and this will occur. Okay. Okay. So this splice site mutation, this is the most common pathology, and the mutation is most common mutation which is known by this name is called as IVS 15G2C mutation. IVS 15GC mutation. Okay, this is the guanine to cytosine mutation. Guanine to cytosine, you might have guessed. Guanine to cytosine will occur. Cytosine in intervening site of intron 1 in the fifth position. Intron 1, fifth position, guanine to cytosine mutation. Right? This is the mutation. Okay. This is the most common mutation. Other mutations are there. Other mutations like your 619BP mutation, 619BP deletion. Okay. And promoter region mutation. Promoter region mutation. So these are the few of the mutations or etiology and the pathogenesis. Right? Pathogenesis, we'll see. Okay. Okay. So we know about this now. And inheritance will be just like your sickle cell anemia. It is a autosomal recessive condition. Autosomal recessive condition. Okay. Pathogenesis will be that there's a decrease beta means increase alpha, decrease beta chains. That means increase in alpha chains. It will form clumps. It will form clumps. Okay. It will form clumps. So this increase alpha chains in the pro-erythroblastic stage, of course, it is a genetic condition. So it will start from pro-erythroblastic that state. Okay, it will start from the pro-erythroblastic state. So what that will be happening is that the pathogenesis basically will be like that. In the pro-erythroblastic state, it can damage some pro-erythroblasts also. It can damage some pro-erythroblasts. This type of, let's say this is a pro-erythroblast, right? Just assume this is a pro-erythroblast, and here we have a more of alpha chains. Alpha chains more. This is a pro-erythroblast. Some will be destroyed and some will survive. Okay, some are destroyed and some which survive will have different anomalies. Some will be hypochromic due to decreased hemoglobin. Okay, some will have abnormal shape of RBCs. Some will produce RBCs of different shapes. So we can have poikilocytosis here, poikilocytosis here. Okay, some will have uh, a distorted shape. Okay, this poikilocytosis only. Okay, like this, distorted shape. Some can produce target cells here. Target cells may be there. Okay, and some will have blast can become small. So we'll have microcytic RBCs. Okay, so hypochromic means decreased hemoglobin, absence of much hemoglobin. So we'll have more than one third pallor. Okay, and again another thing will be there that there is a decreased blasts. Right, some blasts have died, some are destroyed. So there is a decreased blasts means the bone marrow will think that it is not working well. The bone marrow will increase step of production, increase production. So there is a bone marrow hyperplasia associated with that hyperplasia. Then again, it is some will die, half will die because there is a genetic abnormality. Half die plus half survive. Again, it will think survive. So again, it will think and start producing bone marrow hyperplasia. So this type of cycle will continue. This type of cycle is called as inefficient erythropoiesis. So this after this inefficient erythropoiesis, the spleen will start to help. The spleen tries to help. Tries to help. If the spleen tries to help, it starts hematopoiesis again. Starts hematopoiesis. But it is also insufficient. It will be also insufficient. Genetic abnormality will manifest higher. Okay. So there will be splenomegaly. Understood? There will be splenomegaly associated with this. Okay. So basically, these are the manifestations. And bone marrow will have more hyperplasia. So it will require more oxygen. So oxygen demand will, sorry, iron demand will increase. Increase iron demand. Increase iron demand means the body increase absorption of iron. Will increase the absorption of iron means there will be secondary iron overload as well. Okay, known as secondary hemosiderosis. Secondary iron overload, secondary iron that hemosiderosis associated with this. So for treatment, what you can do, you can give iron chelators. For treatment, you can do iron chelators. You can give iron chelators, right? And bone marrow increase hyperplasia means many things will be there. Increase in bone marrow hyperplasia means there will be many things associated with it. First thing, there will be chipmunk facies. One thing called the chipmunk facies. Chipmunk facies. Chipmunk facies means there is an increase in growth of parietal bone and increase in zygomatic arch. Okay, increase parietal or frontal bone growth or increase growth of zygomatic arch. Okay, so will be that chipmunk facies, right? Then after chipmunk facies, another thing will occur that in thalassemia patients, the skull, if you look at the skull, we have a very peculiar appearance of skull in this thalassemia. The skull will have some lines like this. Okay, the bony trabeculae of skull will be thickened like this. These are the bony trabeculae of skull. Okay, increased growth of bony trabeculae of the skull, that the bone marrow will be present inside it. Okay, due to hyperplasia of bone marrow. So of the skull we have a radiological appearance. So radiology, there's a radiological finding which is called as the hair on end appearance. Hair on end appearance, or the crew cut appearance. Hair on end or the crew cut appearance. Okay, if I have a photo, just let me show you. Okay, here you can see the radiological finding also. This is the hair on end appearance. You can see this hair type of structures, right? These are the hair on end appearance or crew cut appearance. Okay, this is the radiology, and this is important. Done. So these are the clinical features, and on lateral view X-ray we find this. Okay. Okay. Then what are the presenting chief complaints or the presenting features? Okay. Chief complaints or the clinical features, you can say. First thing is that it will be manifested after 6 months, because till 6 months we have HbF present till 6 months. HbF is present till 6 months. So after 6 months it will be present, manifested. Okay. We'll have failure to thrive, developmental delays, this type of appearances, and this type of bone deformities. Non-specific symptoms are like weakness, tiredness, etc. Right? These are the beta thalassemia. And CBC findings will be there. CBC findings will be there. All will decrease. Okay. It will cause decrease MCV, decrease mean corpuscular hemoglobin. That is, the anemia is called as a microcytic hypochromic. Microcytic hypochromic. Understood? Microcytic hypochromic, how it occurs? I told you. Hypochromic due to decreased hemoglobin, and microcytic because blast can become small. Okay. Understood? This type of pathogenesis is important. This pathogenesis is given in Robin's book very beautifully. You can see from that also. Okay. And first year students, if you're finding it a bit to a higher level, I told you from the beginning that we are gonna dive into the anemias at a more higher level and a more complicated level, as much you require. So as much you require, you can just get from that. And if you're this type of things I am telling you, because in future also you'll be needing it. Okay, hair and hand appearance. If you write also in your first year MBs, then it will be like a very good thing. Okay, you'll get very good marks or distinction and all. Okay. And again, another finding will be that it will be producing the iron deficiency anemia. So it will have a wider RDW and more than 13 Menzer index. Right. Peripheral smear, what you will found? Peripheral smear will have a variety of things. Okay. First thing you can write anisopoikilocytosis and poikilocytosis. And microcytic hypochromic anemia will be there. You can see target cells and spirocytes also. Target cells present, spirocytes may be present. Okay. Investigation of choice is your hemoglobin electrophoresis. But a better thing, a better that you can say way is called as your HPLC. HPLC. Okay, HPLC is a high pressure liquid chromatography. HPLC. Understood. So blood is taken and hemoglobin is removed, kept in an electrophoretic chamber and monitored for mobility. Okay. So if you remove, basically in this process, you remove the blood, you remove the hemoglobin and keep in a electrophoretic chamber like this, electrophoretic chamber, and based on mobilities, you are basically judging it and comparing it with control. Okay. So in thalassemia, what happens? There is a finding called, in thalassemia there is increase A2, increase A2, HbA2 levels. Okay, HbA2 levels, increase HbA2 levels in thalassemia means. Okay, uh, okay. So these are the things. And if I show you some of the HPLC findings, you might require that. Okay, so I am just finding if I have a picture, or else we can do HPLC and findings in another short video. Just let me find. Okay, HBLC we can do any other lecture. First, you can see the hemoglobin electrophoretic findings. HBLC will take time as it has very many graphs present. Okay, so basically, yeah. So basically, let's see at the hemoglobin electrophoresis findings. Okay, so here's the normal HbA2. This is the HbF and HbA present. Okay, in beta thalassemia major, what you'll see it increase a little bit increase in HbA2. So A2 will increase and increase in HbF2. HbF also increases. Okay, your HbF also increases in a thalassemia major. So thalassemia major will have HbA2 increase and HbF increase. In beta thalassemia trait, in a beta thalassemia trait, okay, you'll see an increase in HbA2 and an increase in HbA. So HbA2 increase and HbA increase. Okay. HbA is nearly normal. A little bit increase occurs. You can just write HbA2 increase. Okay. And in beta thalassemia, this much pictures are there, and I'm writing other findings. In beta thalassemia, minor, major is done, right? Yeah, major is done. Minor, you will see HbA2 increase. Okay, HbA2 increase. So, like that, we can have for sickle cell anemia also. Sickle cell anemia also. So in sickle cell anemia, for sickle cell trait, HB, that sickle cell trait means HBAS, right? HBAS you can write. So HB here, the band for HBS will increase in breadth, and for sickle cell anemia disease, that is HBSS, your HBS will be positive, that will be present, increase width. Okay, increase width. Okay, HBS will be positive, increase width, and HBF will also increase. That's the sickle cell disease. Okay, for screening the thalassemia minor, we have something called as a just a minute, Nestroft test. Nestroft test for screening thalassemia minor. So Nestroft test stands for naked eye, single tube, red cell, osmolarity, fragility test. Okay, naked eye, single tube, red cell, osmolarity, fragility test. So basically, whenever we know that there is a spirocyte, there is bursting. Okay, and normal, if you put a 0.36% saline is there and you put the blood, then RBC will be rise, and there will be clear supernatant, and the RBCs will settle down. But if there is a thalassemia patient, okay, if you take 0.3% saline here, and put a drop of blood in it. There is no lysis, that is a red supernatant will be produced. This is called as Nestrov positive. Okay, and Nestrov positive means conclusion is that we have microcytic RBCs. So basically, whenever there is a microcytic RBC, like a small RBC, it acts like a balloon. Okay, it acts like a balloon and changes to a normal RBC. So there is no lysis, right? Done. So that's about beta thalassemia. We discussed a lot about beta thalassemia, I guess. So this semi-quantitative beta thalassemia, we talked about that minor and major, and most common is the splice site mutation. Most common out of that is IVS 15GC mutation. Then we can have 69BP deletion and promoter region mutation. Autosomal recessive condition. Pathogenesis: decrease beta chain means increase alpha, means clumping means destruction. Either can destroy it. If it gets destroyed, then the bone marrow steps up production, means there is a increased iron demand and secondary iron overload causing secondary hemosiderosis, or it increases production causing bone marrow hyperplasia, in which half will die. Okay, so increased production mean bone marrow hyperplasia and half die, half survive. So there is inefficient erythropoiesis. Spleen tries to help, and characteristically splenomegaly will occur. Treatment is by iron chelators because there is secondary iron overload. So you can chelate the iron to decrease it. Increased bone marrow hyperplasia means there will be occurring of chipmunk facies and increased parietal or frontal growth, increased growth of zygomatic arch, chipmunk facies, and bony trabeculae of skull will increase growth. So we will have hair on end appearance or crew cut appearance. So you can see the crew cut appearance here. Clinical features will be manifested after 6 months: failure to thrive, developmental delays, bone deformities, weakness and tiredness are non-general symptoms, or general symptoms, sorry. CBC will have decreased MCB and MCH, that is microcytic hypochromic anemia, wider RDW, and more than 13 Medger index. Peripheral smear will have anisopoikilocytosis, microcytic hypochromic anemia, target cells will be present, spherocytosis may be present. Spherocytes may be present or absent. Investigation of choice is HB electrophoresis, you can see. So in beta thalassemia major we'll have A2 and HbF increasing, minor will have HbA2 only increasing, and trait will have HbA2 only increasing. For sickle cell trait we have HbS increasing, and sickle cell disease will have HbS and HbF increasing, right? Nestrov test we know: naked eye, cell tube, red cell osmolarity fragility test, naked eye, single tube, red cell osmolarity fragility test. In this thalassemia patient having a microcytic RBC will have no lysis, so red supernatant will be there, but in a normal patient, a normal individual will have clear supernatant, right? Understood? So these are the things, and if I just give a overview of alpha thalassemia, not much important. Alpha thalassemia. So alpha thalassemia we have 4 alleles, right? So alpha and alpha. These are the normal patient. Okay, normal individual, not the patient. Or alpha, one allele is mutated, one allele deletion, one alpha is deletion. Okay, so it is a silent mutation. And asymptomatic patient. So we can have this type of thing also. There is no effects, and alpha and both alpha are deleted. So this is called alpha thalassemia trait, which is very similar to beta thalassemia minor, minor, right? And deletion. This is called HbH disease, okay, where beta 4 tetramer is found here. Beta 4 tetramer is found, and there is hemolytic anemia. There is a characteristic finding here which is called as the golf ball inclusion. Gall ball inclusion is found on NMB stain, new methylene blue stain, NMB stain. Okay, gall ball inclusion. So this is a characteristic gall ball inclusion. You can see these are the gall ball inclusions, right? You can see here, and we have lastly all 4 chains mutated or deleted. 4 alpha deleted. Okay, here gamma 4 tetramer is found. Gamma 4 tetramer is found. Gamma 4 tetramer is found, and gamma 4 tetramer will cause the formation of hemoglobin BARTs, or BART hemoglobin it is called as. You can write hemoglobin BART formation, right? And gamma 4 tetramer, because you know that gamma has increased capacity of holding oxygen, so there will be increased capacity of gamma. Fetus will hold back oxygen. It will cause fetal hypoxia, and fetal hypoxia will lead to hydrops fetalis, which is fetal in utero death, which will cause in utero death, right? And the best treatment, lastly, the best treatment of anyone, the alpha or beta thalassemia, is bone marrow transfusion. Okay, so that's about thalassemia in total, and then we'll move to our next disorder, and that is paroxysmal nocturnal hemoglobinuria, or PNH. Okay, talking about paroxysmal nocturnal hemoglobinuria, what happens is that, let's say here is our RBC. So we have something called as a GPI anchor. This is the GPI anchor and GPI anchor, and we have CD55 being held tightly to it, CD55, and here we have the CD59. Okay, CD55 and CD59. Here in PNH, what happens is that there is an acquired mutation in PIGA gene, due to which codes for this GPI. So if there is a mutation, this GPI is destroyed, the CD59 is destroyed. In a normal individual, this when we sleep, there is respiratory alkalosis, which activates the complements, and C5 to C5, C6, C7, and some molecules of C9. This forms a MAC, membrane attack complex, and if this is present in plasma, it must destroy RBCs and other blood cells also. Okay, it must destroy RBCs. So we'll have hematuria in morning. But we don't have due to CD55 and CD59. These are the protective molecules. So CD55, this is called as a decay accelerating factor. Okay, DAF. So this is the decay accelerating factor which destroys C3 convertase enzyme. If you have read the complement pathway, you can correlate well. If you haven't read, just remember, destroys the C3 convertase, which will stop the complement pathway. Stop this formation of MAC. This MAC won't form, and there is no hematuria in normal person. Or CD59 is also called as the MIRL. MIRL means membrane inhibitor of reactive lysis. Okay, this will also destroy the MAC. destroy MAC. So there is no hematuria in morning in a normal person. Okay, but here in PNH, what happens? I told that there is an acquired mutation in PIGA gene. This PIGA gene which was coding for this GPI. So this will be destroyed, and CD55 and 59 will be destroyed. So as a result, in PNH, this all things will be happening during sleep. There is alkalosis, complement activation, destruction, and so we'll have hematuria in the morning. Okay. So sleep, hemolysis, morning we have hematuria. Only the first sample, okay, only the first sample, and WBC and platelets will be also destroyed. Okay, so we can say that we have a pancytopenic state, pancytopenia present. Okay, and the thrombocytopenia also present, leukocytopenia also present. Okay, and thrombocytopenia and this all. So there is an increased risk of thrombosis also, which is the most common cause of death. Thrombosis, the most common cause of death in PNH. Thrombosis, you know from your previous discussions, it can form an emboli and can travel throughout and destroy many things, right? Here, if we examine the bone marrow, we'll find a cellular bone marrow only. Okay, cellular bone marrow, because bone marrow is not affected now, right? Bone marrow is not affected. That's just the peripheral blood is affected. That means that you can diagnose it. Just a minute. Okay, you can differentiate it from aplastic anemia, because this cellular bone marrow will rule out your aplastic anemia, because in pancytopenia is also present in aplastic anemia, so rules out aplastic anemia, because here bone marrow is destroyed. Here we have a normal cellular bone marrow, right? Then we'll talk about the peripheral smear. Peripheral smear will be normal because there's a uniform destruction, right? It is normal. Diagnosis is by flow cytometry, where we'll target the GPI targeted, and we can use FLAIR dye, which is the best dye available, fluoro, fluoroaerolysine dye, FLAIR dye, right? And you can also target CD55 and 59 also. You can also target this. And treatment, first is the bone marrow transplantation. Or you can give orphan drug, you know, which are for rare diseases. You can do eculizumab, monoclonal antibody, eculizumab can be given. Okay, and this eculizumab is a expensive drug, is a C5 inhibitor drug, right? But it is very effective. It can decrease the risk of thrombosis up to 90%, right? So these are all about PNH. So PNH you understood. This was the pathway which you have to understood. This was the that pathology part, and bone marrow, peripheral smear and diagnosis, it's obvious, and treatment is eculizumab and bone marrow transplantation, right? Then we have a very important disease. This was, I guess, the fifth, yes, and the sixth one is called as the autoimmune hemolytic anemia, AIHA. You must have heard autoimmune hemolytic anemia. So it has basically two types: warm AIHA, and one is called the cold AIHA. Warm AIHA and the cold AIHA. Warm AIHA is the most common type, okay, and this cold AIHA is a bit rare, you can say. Etiology, if I talk about etiology, it can be drug induced, it can be this warm okay, can be drug induced, can be seen SLE, can be seen in chronic lymphoid leukemia, okay, or can be seen idiopathically, okay, right. So some drugs like penicillin and alpha methyl dopa can cause this warm EIHA also, okay. So talking about the etiology, if I talk about etiology, so primary one is idiopathic, and secondary it may be seen in SLE. It may be seen with respect to drugs like penicillin and alpha methyl dopa, or it may be seen in CLR, right. Here the IgG antibody is formed against formed against RH antigen, okay. IgG antibody is formed against RH antigen. Understood? So let us give this lecture here because the weather is not fine and it's night already. I got busy in a work, so we'll continue from this in lecture 2 of anemia. Okay, so this is the part 1. This is the part 1, and in the part 2 video we are gonna continue from the warm AIHA. We'll start from the AIHA like that. Okay, we'll continue from here, continue in part 2. Okay, so that's all in today's lecture. If you have any doubts, you can reach out to me at Instagram at Biswanath Tripathy _ okay. For any doubts you can reach to me. So that's all in today's lecture. Thank you and have a great day ahead. Good night.